Welcome, everyone, and thank you for joining us for today's session on pioneering our understanding of the human brain. I'd like to introduce Dr. Wolf-Julian Neumann, who is a clinician scientist in the Movement Disorders and Neuromodulation Unit in the Department of Neurology at Charité, Universitätsmedizin Berlin, Germany. Dr. Neumann's work combines computational modeling, deep learning, structural and functional connectivity mapping, invasive and non-invasive recordings to elucidate the role of the basal ganglia in health and disease. For a complete biography on our speaker, please visit the Biography tab at the top of your screen. Dr. Neumann's talk title is Towards Artificial Intelligence-Based Adaptive Deep Brain Stimulation in Movement Disorders. My name is Dr. Roshan Akashimyan, and I will be your moderator for today's event. We are delighted to bring you this educational web seminar presented by LabRoots. We would like to extend our special thanks to the Brain Initiative Program Directors, and in particular, Dr. James Natt, for their efforts in organizing today's session. Before we begin, I would like to remind everyone that this event is interactive. We encourage you to participate by submitting questions during the presentation. Simply click on the Ask a Question box located on the far left of your screen and type your questions in the drop-down box. Our speaker will respond to your questions via email following the presentation. This presentation is educational and thus offers free continuing education credits. Please click on the Continuing Education Credits tab located at the top right corner of the presentation window and follow the process to obtain your credits. Now, without further ado, please join me in welcoming Dr. Neumann.
Okay, thank you for the introduction. Now, here's my perspective on what is coming up in the next few years in the field of deep brain stimulation for movement disorders. For those of you who don't know, deep brain stimulation, it's a very effective treatment for different movement disorders like Parkinson's disease, dystonia, and tremor patients who are not sufficiently alleviated in their symptoms through medication. And therefore, then a DBS electrode is implanted into the depths of the brain at specific targets depending on the disorder and the indication. And another battery aggregate, the so-called impulse generator, is implanted under the skin in the chest or abdominal wall. And this gives opportunity to test functional connections of the targets and to have a robust way to develop next generation clinical brain-computer interfaces, because it's a very effective treatment that creates reproducible both behavioral and clinical effects. And this is also inspired by this landmark paper by Peter Brown's group, who is in Oxford. And he has shown that deep brain stimulation can be used in a closed loop fashion by recording electrophysiological activity from the electrodes that are implanted into the depths of the brain, and using this electrophysiological activity to trigger stimulation in real time. So here you can see on the left side the recording setup with this DBS electrodes inside the brain, and the signal, like an internal or invasive EEG signal, is being captured by an external computer via externalized leads, and the stimulation is triggered dependent on the activity that is measured. And strikingly, this publication could show that even though only half the time of stimulation was present, it was more effective than the continuous stimulation paradigm that is traditionally being used in the clinics and still is the only currently available treatment for as a model for DBS. And importantly, they also controlled for random pattern stimulation, and the ADBS that was triggered by the electrophysiology was more effective than either continuous or random pattern stimulation. And this has really inspired the search for biomarkers, and was also inspired by the fact that we can really record pathological activity that is characterized dependent on the different neurological disorders that we are investigating. And as I said, biomarkers are important in this case, and we have, in addition to beta activity that was used in the mentioned publication, characterized many biomarkers in different diseases, and I'm going to introduce a few to you that are important in my view. In Parkinson's disease, as I said before, beta activity in the 13 to 30 hertz range is the hallmark of the PD off state. So when the patients refrain from taking their medication for a certain time period, they develop beta activity, and this can be recorded via DBS leads from the depths of the basal ganglia. Now, not only can it be recorded directly during the surgery or a few days after the surgery, it is also now possible to use implantable devices to record activity after a month of DBS implantation. And we could show that there is a robust measurement of activity in the beta frequency range possible in PD patients when they're off medication. This highlights its usefulness as a biomarker. And not only is it there, it's also correlated with disease-specific symptoms, especially bradykinesia and rigidity in PD patients. But we have also looked at other movement disorders, and dystonia is a disorder that is associated with involuntary muscle contractions. And in these patients, the internal pallidum is the target that can be very effective in treating the disorder. We have characterized local field potentials from the pallidum in these patients and found that both low frequency or theta range activity typically in the 3 to 12 hertz range, as well as beta activity is measurable in these patients, but using different modalities and different analytic approaches, there was only a hint towards a pathological relevance in the low frequency or theta frequency range, while beta power was not associated with symptom severity in these patients. Also, neuropsychiatric diseases can be characterized in their neurological or neurophysiological fingerprints. And on the upper half of the slide, you can see our paper on major depressive disorder. Here we could record in the limbic system, in the anterior cingulate cortex or the bad nucleus of stria terminalis, and found that depressed patients have higher alpha band in the limbic system, and that the amount of alpha oscillations there is correlated with the self-rated depressive symptoms. In Tourette's syndrome, another hyperkinetic group, in the pallidum and thalamus, there's strong theta activity that is also coupled between pallidum and thalamus. And using a multivariate approach, including low frequency and beta frequency activity for both targets, we could very reliably predict symptom severity in these patients, particularly for the motor symptoms. So, concluding, there are now many different biomarkers of movement disorders in local field potential activity, and we have, alongside with other groups, made an effort to really try and find symptom-specific oscillations or symptom-specific markers in activity that can be recorded via DBS leads and potentially used for a closed loop or adaptive BCI application in DBS. And this gives an overview that with this figure is also published in our review on this from this year. And it mainly shows you that there's a lot going on in the different frequency ranges, and in the low frequency range, there is a tendency to reflect hyperkinesia. So 4 to 12 hertz activities seem to be associated with excessive movement, whereas higher activity in the beta frequency range seems to be associated with lack of movement, akinesia, bradykinesia, and rigidity. So if we have all these biomarkers, why is artificial intelligence needed? And if we can just use one biomarker and trigger stimulation whenever it is up or high, why do we need a more sophisticated computational approach? We have recently characterized specific effects of DBS on specific pathways in this publication from 2018, where we looked at the effect of cognitive control and motor symptoms or kinematic effect. And this is a study conducted in 20 patients with Parkinson's disease. And we could show that depending on the pathway that we're stimulating, we're modulating physiologically relevant or normal activity via the hyperdirect pathway, for example, and the kinematic aspect and the clinical symptom severity is modulated mainly via the indirect pathway. And what this is showing is not only that the DBS effects depend on pathways, but also on the patient. So we need a temporal specificity, and we need to be able to adapt DBS to the concurrent demand. So here I give some example why this could help in the clinical setting. Some DBS parameters have been reported to be better for certain symptoms or certain behavior in patients. For example, improved freezing of gait was reported through 60 hertz stimulation and also through using ventral DBS in the substantia nigra instead of the subthalamic nucleus. So if a patient walks, we might want to change the stimulation to a setting that is better for walking for the patient, while when he sits, we want to have the most effective stimulation for example, upper limb motor control. Then dyskinesia is a problem or a side effect of medication and stimulation. And many patients still take medication when they're on DBS. So the clinician on the clinical ward, on the neurological ward, needs to find a setting that somehow balances medication effects that wax and wane alongside the chronic DBS. Now, if we could predict or know when a patient has dyskinesias and we could adapt the stimulation accordingly, this could significantly improve the stability of the clinical effect in PD patients. Now, finally, speech can be affected by DBS or also by the movement disorders, and certain stimulation settings may improve speech, or even sometimes reducing the stimulation amplitude can improve speech. So if we could know when a patient is speaking, just from recording and electrophysiology, we could improve the outcome of the DBS intervention for these patients. So ultimately, our long-term goal should be to develop an intelligent closed-loop adaptive stimulation that is an assistive neuroprosthetic, and something that might show us where this can go is the computational model of the basal ganglia developed by Henning Schroll and Fred Ramka, who have created a firing rate model that can predict behavior in this publication. And have a look at this 3D video of the different brain areas interacting together in the model, which can predict behavior, actual behavior of the patient. So what we saw was the interaction of cortex and basal ganglia, and this kind of reflects the design that I want to introduce to you here, which covers recording of input and output signals. So most of the biomarkers that I presented before were recorded in the actual basal ganglia output part, either the pallidum or the epithalamic nucleus. But to be able to create a neuroprosthetic, we should have somehow some input into our model, for example, as exhibited in the video before. And then we can somehow connect these inputs and outputs to a neural interface that monitors and minimizes pathological activity and creates a synthesized output or a modulated neural output through stimulation. So to be able to do that, we should try to understand what DBS actually does in target. And there's a really amazing study published in 2018 by Richardson's group, spearheaded by Luka Milosevic in Toronto, and they have shown that DBS leads to local suppression of spike firing and to potentially through GABA-mediated silencing, and it also has plastic effects on GABAergic neurons. So this gives us a good proxy of what is going on the spiking activity through DBS. On the network level, there's another great paper by Vladimir Litvak and Peter Brown's groups, spearheaded by Ash Oswald, and they have shown using a combination of local potentials and MEG that DBS modulates network activity, potentially via modulation of spike firing, but independent of that, oscillatory connectivity is reduced through stimulation in specific spectral frequency ranges, and also the spatial distribution of these frequency ranges is different and dependent on the pathway. So cortical activity seems to be a relevant proxy of input, not only based on our anatomical knowledge of corticostriatal and corticocephalemic pathway, but also on the basis of neural modulation that has been shown also by Philip Starr's group, for example, great work on the subthalamic DBS modulation of cortical activity. So this somehow gets us to the point where we should try and to think about ways to record cortical activity. And Philip Starr in San Francisco really has developed and pioneered this technique in movement disorders using electrocorticography or ECOG strips that can be used potentially for adaptive DBS. And versus the traditional strict LFP recordings, this has several advantages. It is compatible with any DBS electrode design, including segmented or directional leads. It has a very good signal-to-noise ratio compared to LFP. It has the opportunity, or gives the opportunity, to place the sensing electrode independent of the DBS target, and it allows a large area to be covered. the number of potential stimulation contacts is also unaffected. But we should remember that it is additionally invasive and the clinical use is less research. So using ECOG, we have now investigated the potential to predict or decode behavior using the learning framework based on input signals that are decomposed into frequency ranges. And we can show in the following video that it is performing really well. And we can, for example, decode gripping force from the patient just based on electrophysiological. So such a framework can be used to move towards high precision, personalized adaptive DBS paradigm using artificial intelligence by creating a combined ECOG LFP framework that senses different features and feeds a deep learning computational network that can decode, for example, dysarthria, freezing of gait, walking, dyskinesia, tremor, bradykinesia, and PD. And then we can use this information that is decoded from the interface to adapt the stimulation parameters, such as pulse width, frequency, amplitude, and contact. Now, there are open questions, and there's research to be done in the preclinical state. And right now, I want to highlight some of them. We should try to really understand the correlates of MRI connectivity, like fMRI resting state and oscillations, because fMRI is readily available in all clinical departments, while whole head cortical recordings are less available also for ECOG research. So if we had a better knowledge of what is going on at the cortical level in PD, we should be able to better place ECOG in the aim to decode whatever we want to decode. Then we don't have good predictors of PD phenotype for decoding. So if a patient has tremor or is a bradykinetic rigid kind, we don't know yet whether we should aim for a different ECOG trajectory. So generally, we should analyze facial patterns of symptom-specific predictors, and then we can prototype sensing montage for optimal prediction of individual symptoms using such cortical maps derived from whole head magnetoencephalography or fMRI connectivity. So this concludes my talk. I want to thank you for your attention, and I would also like to thank my collaborators, most importantly, Andrea Kühn, who is the director of our Movement Disorder and Neuromodulation unit, and then our collaborator, Vladimir Litvak, who is associate professor at UCL, and Mark Richardson, who is in Pittsburgh. Thank you.
Dr. Neumann, thank you very much for that exciting talk. As a reminder, our speaker will be available to answer any questions about his presentation by email. Now, coming up next, we will further explore the role of the cortical basal ganglia circuit in Dr. Mark Richardson's presentation, Basal Ganglia Cortical Loop Function During Speech. See you there.